So you bring up one of the issues now. We see this now with cladribine. We have it with alemtuzumab, and we have it with the autologous hematogenous stem cell transplantation, the bone marrow transplant, and that you get a period of time where you're not doing anything therapeutically where people have some degree of protection. None of them is a cure, right? So there's different cost effectiveness. One of the things I'm struggling with this is when do you restart the therapy? If you hope that you're going to see something on the MRI as the first sign, then that may be okay because MRI is very sensitive. But if the next event is a relapse, and that's what you make the decision off of, well, 50% of relapses leave some residual. And so you probably waited too long. And so how are we going to make that decision of how long? I mean, here you have data for 2 years. It's group data, right? Not individual data. Same thing with alemtuzumab. There's some people who fail all along. And if you look at the well-done autologous hematogenous stem cell transplants, they all have a failure rate, you know, out through 2 years and moving onward, and some more than others. So how are we going to be able to protect those individuals?
So, you know, theoretically, when I look at the target of the drug and see if that target is adequately suppressed or modified, for example, if you're using a B-cell depleting agent, you would hope that B-cell counts, CD19, for example, would be a good indicator when to administer the next dose. But as you pointed out, patients may have a relapse before then, while their CD19 are still undetectable. What does this tell us? It probably tells us that it's working through additional mechanisms. And maybe that's not the absolute biomarker for timing the next dose of the drug. And one could say the same thing for alemtuzumab. You might have suppression of a lot of the target cells, the CD52 cells, yet the patient might have a relapse. Well, what could be happening is that maybe those patients have not yet developed regulatory T cells, which we know that in the context of alemtuzumab do appear later in the disease during the treatment course. So the point I'm trying to make is that we try to use the target of the drug as an indicator for dosing, but it is not always the case that they're predictive. But they do tell us that these drugs, while we think they work through one mechanism, they probably involve several mechanisms, some of which we don't know.
And it's already been raised, the issue of what do you do with people when they have no T cells and are having an attack, let alone just not having B cells? And I think that's still an open question as to what to do then.
We obviously also need to keep in mind that what we measure peripherally in B cells or T cells is not necessarily completely reflective what's present within the tissues. And so while the peripheral the component of the lymphocytes is certainly something that we traditionally measure and look at, it may not necessarily fully inform us in these treatments how it is actually represented in the target or how it regulates the disease process.
There's some rather old EAE data in irradiated mice that show you can get attack of the nervous system with very few T cells and still produce damage.